Welcome to the topic Approach to Altered Mental Status in the Core Knowledge module. Here we will be looking at the 4 steps in the assessment process of the Glasgow Coma Scale, or commonly known as GCS in short. The Glasgow Coma Scale, or GCS, is an objective clinical scale used to reliably measure a person's level of consciousness. It was initially used on patients who sustained head or brain injuries. This scale was adopted by the Neurosurgical Nursing Unit and subsequently now being used by all specialties in the evaluation of one's conscious state. The GCS assesses a person based on their ability to perform eye movements, speak, and move their body. These 3 behaviors make up the 3 elements of the scale, which are eye, verbal, and motor response. A person's GCS can range from 3, which is completely unresponsive, to 15, fully responsive. The GCS assessment aid has 4 steps to the assessment process, which begins with check, followed by observe, next would be stimulate, and finally rate. The assessor should evaluate each of the subscales as listed in the assessment aid. Each subscale has several components, so based on the level of consciousness, a score is assigned. A higher score indicates a greater level of consciousness. Let's look at the approach. First and foremost, verify the symptoms and signs. Attend to the patient by identifying the correct patient and verifying the name. Ascertain what was the patient's baseline GCS upon the last review from documentation available. Look at the patient's general appearance, such as if the patient is having a blank stare, or is there rigidity, having a seizure, cyanotic, restless, or agitated. Assess the GCS by speaking to the patient loud and clearly. Let's look at the examination process. We begin with the eye response, which is using sound and touch. If the eye opens spontaneously without requiring call or tapping, that would be a score 4. Hello sir or madam, are you feeling all right? Now the eye opens to call. That would be score 3. If no eye opening to call, tap the patient's shoulders or apply some pressure over the patient's fingertips or the supraorbital notch. If the eye opens to pain stimulus, that will mean a score 2. And if no eye opening at all despite calling or applying pain stimulus, that means it's a score 1. Now let's look at the verbal response using just sounds only. If patient is able to respond to your call verbally and coherently, as well as able to answer questions asked of him or her, such as name, place and day, that would be a score 5 because the patient is orientated. Now, if the patient is able to respond to your call verbally, however, fails to answer questions asked of him or her, such as his name, place and day, the score would be 4 because the patient is confused. If the patient is able to only respond with comprehensible words, that would mean a score 3. And if you find the patient responding by moaning or groaning, which means only sounds are made, that is a score 2. Finally, if there's no audible response to your call, that's a score 1. Next would look at best motor response by using sound and touch. If the patient is able to obey your 2-step command, such as blink your eyes and raise your arms, or blink your eyes and clench my fingers, that would be a score 6. If patient is not able to obey your command as above, apply some pressure over the forehead or chest with your thumb. If the patient raises either of his hands towards the pressure, which means localizing the pain, that will be a score 5. If the patient responds to the pressure applied by bending his arm rapidly away from his body, that would be normal flexion and means a score 4. If the patient responds to the pressure applied by bending his arm slowly across his chest with his thumb clenched and legs extended, That would be an abnormal flexion, means a score 3. And finally, if the patient responds to the pressure applied by extending his arm at the elbow, it's a score 2. Just like every other components, if the patient has got no response in both arms or legs, that would mean it's a score 1. Now let's look at the difference between score 3 and 4 in terms of flexion responses. We have the abnormal flexion and the normal flexion. So for a normal flexion, it is a rapid response, variable, and the arm moves away from the body. That would mean a score 4. For an abnormal flexion, which is a score 3, it will be typically slow. The arm will cross the chest, the forearm rotates, the thumb becomes clenched, and the legs extend. And that would make a score 3. Whilst you are assessing the patient's GCS as per guide, we should also complete by 1 minute at most. Use the assistance of the ward staff nurse to gather patient's vital signs by placing the relevant monitors, such as your blood pressure cuff connected to a monitor, your pulse oximeter, and your cardiac monitor on the patient. Check the patient's capillary blood glucose, or in some places it may be called dextrosticks or DXT, or hypocount or HPC. If patient's capillary blood glucose is less than 4 millimoles per liter, immediately administer 50 cc of intravenous dextrose 50% solution and place the patient on a dextrose 10% drip. Reassess the patient's capillary blood glucose every 5 to 10 minutes and repeat until the readings are stable and the patient is fully aware. Once you have objectively evaluated the drop in GCS, get the assistance of your staff nurse to relay the score and vital signs to your medical officer and request for further help. Stay by the patient at all times. You may start initial measures by providing oxygen supplement if you find that the patient has a suboptimal oxygen saturation, which is less than 95%. Examine the areas using the ABC approach. A. Airway. Is there any gurgling sounds heard? B. Which is breathing. Is there abnormal breathing pattern observed, whether rapid or too slow? You will be able to gather this information from the initial assessment of respiratory rate. And C. Circulation, blood pressure, whether it is recordable, and pulse well felt. Look at the pupils to assess the size and the reaction to light, and if there's any presence of ophthalmoplegia, deviation to a particular direction. That might give you some clues to what might be going on with the patient. Next is the chest examination. Listen to the heart sounds, abnormal sounds like murmurs, reduced or absent breath sounds, crepitations, rhonchi, that will give you further information on the pulmonary problems that the patient might be having, giving rise to altered mental status. And finally, your neurological examination. Examine the muscle tone, deep tendon reflexes, and plantar response. What would you do next? So there are a couple of blood tests, bedside tests that can be conducted, and these will give you more information to how severe the problem is or to what the problem may be. These tests are done with the help of ward nurses. At least one large bore intravenous cannula needs to be inserted. There has to be a 12-lead ECG done, preferably a serial ECG, which means at least 3 ECGs done at an interval of 5 to 10 minutes, and oxygen supplementation based on the oxygen saturation seen on pulse oximetry. This is a flow on oxygen supplementation therapy. It is referenced from the British Thoracic Society guidelines. Begin with titrating oxygen up or down to maintain the target oxygen saturation. This flowchart shows the available options for stepping dosage up or down. The chart does not imply any equivalence of dose between venturi mask and nasal cannula. Allow at least 5 minutes at each dose before adjusting upwards or downwards except with major sudden fall in saturations, which is more than 3%, also requiring clinical review. Once your patient has adequate and stable saturation on minimal oxygen dose, consider discontinuing. Once your patient has adequate and stable saturation on minimal oxygen dose, consider discontinuing oxygen therapy. Seek your senior's input as soon as patient requires more oxygen requirement. How about instant tests? Other tests that can be done include cardiac enzymes, in specific creatinine kinase MB, and high specific troponin I. If raised, most likely it is an acute coronary syndrome. A portable chest X-ray should be done to look for pneumothorax or pneumonia, presence of widened mediastinum. Arterial blood gas sampling is done to assess oxygenation and severity of respiratory failure or acidosis. Serum electrolytes with albumin would give you an idea whether there's presence of electrolyte imbalances, such as hypo or hypercalcemia, hyponatremia, or hypomagnesemia. A full blood count would give you information on presence of leukocytosis, which could indicate sepsis or CNS infection, and reduced hemoglobin in anemia. A renal function test would provide you some information on the presence of high urea levels that could be causing the uremic encephalopathy and altered mental state in the patient. And finally, a liver function test, which could also provide you information on if there's evidence of hepatic encephalopathy, characterized by high bilirubin levels. Now, what are the tests that would require confirmation by your medical officer or superior? A CT brain. So urgent CT brain, which could be a contrasted or a plain scan, to look for intracerebral bleed, infarct, midline shifts, and cerebral edema. Also, if there is need for endotracheal intubation or non-invasive mechanical ventilation, after evaluating blood gas sampling or if the GCS is less than 8 and the patient is unable to maintain a saturation of more than 95%. Not forgetting urine toxicology tests if there is a suspicion of drug intoxication. Stay with the patient at all times until your medical officer arrives. Then you may expedite the transport of blood samples to the lab while ensuring there's always a doctor by the patient. Always reassess the patient with repeat of the steps above after measures have been taken by the medical officer. Your medical officer or surgeon attending will decide the next measures for the patient's care based on the information provided by you earlier on. Now let's look at the potential causes of altered mental status. These are the list of possible causes for drop in GCS. It could be due to cardiac causes such as cardiac arrest, dysfunction or arrhythmias, central nervous system problems such as a stroke, cerebral edema, anything that can lead to raised intracranial pressure, or encephalopathy due to hepatic causes, uremic, or drug intoxication. Respiratory causes include hypoxia and hypercapnia, which leads to respiratory failure, and metabolic problems such as hypo or hyperglycemia, severe metabolic acidosis, and electrolyte imbalances. Finally, to recap, the GCS assessment aid has 4 steps to the assessment process. Remember to check, followed by observe, stimulate, and finally rate. The assessor should evaluate each of the subscales as listed in the assessment aid. Each subscale here has several components, and based on the level of consciousness, a score is assigned. We have come to the end of this topic. Thank you.